No? Yes? All right. Great way to start. Well, I'll appreciate everybody's attendance here. It's always a superb symposium, and I'm honored to have the opportunity to present. My topic this morning is tissue-engineered solutions for aesthetic dilemmas. Now, if you've been attending the conference, you already know that through traditional periodontal plastic surgical procedures, things that you and I do every day, we can predictably increase keratinized tissue. We can predictably cover denuded roots. We're not that good about augmenting papilla, and we rarely can achieve regeneration. Well, I'd like to share with you studies that we're doing today with tissue engineering that's achieving all of these objectives, but at the same time without a donor site, with reduced morbidity, with an unlimited supply of donor material, increased predictability, more robust results, and a more natural outcome. It's appropriate for me to disclose that the following companies have provided support for the research that I'm about to show: Organogenesis, Isologen, OsteoHealth, and Geistlich Pharma. But I always maintain complete control of reporting of all data and the content of my lectures. You know, tissue engineering brings together the power of modern biological, chemical, and physical sciences, and really represents a spectrum or a matrix that provides novel approaches to regenerative problems. And I like to think of tissue engineering as this matrix. In the middle of the matrix, we have biologically based devices. These are biocompatible surfaces that either through physical or chemical signals guide and direct cellular growth. On the other end, we've got bioactive molecule-based devices. Here, the hypothesis is that if you and I can identify the appropriate biologically active molecule, if we can deliver it to the site at the appropriate concentration, at the appropriate length of time, that will cause the cells from the periphery of the defect to migrate in, to proliferate, to differentiate, and to participate in the regenerative process. On the other end of the tissue engineering matrix, we have live cell-based devices. Live cell-based devices have not only cells, but they have glycosaminoglycans, proteins, collagens, all the things necessary for regeneration. And I'd like to present studies that we're using in each of these areas of the tissue engineering matrix. Let's begin with biologically based devices. You know, probably, undoubtedly, the best known biologically based device is the one Dr. Allen just talked about, acellular dermal matrix. You know, it is cadaver skin that they've removed the cells, leaving the extracellular matrix, the collagen. It can support fibroblast migration, revascularization. It is, in essence, an immunologically inert allograft. And by the way, I was instructed, I thought all of the presenters were not to provide any trade names. I've noticed this morning that's not been followed, but you'll see no trade names in my presentation. But since it wasn't followed, I'll start using them as we go along here. The biologically based device that we've been doing research on is a xenogenic collagen matrix. Trade name is Mucograft. One of the things that you'll immediately see with this material is its thickness. It looks very different than any collagen membrane than you've seen before. It's a porcine collagen 1 and 3. It has a cell-occlusive outer layer and then a spongy inner layer. And the interesting thing about this is that this inner layer has both intact and fragmented collagen fibrils. And these collagen fibrils are decrypted. That means that the helix is somewhat unwound. And as you unwind the helix, it exposes previously hidden or decrypted peptide components like RDH. And RDH is important for promoting cell attachment, for angiogenesis, for attracting endothelial cells. And so while you look at the membrane here, the macro structure of the membrane is interesting, but probably it's the microstructure that's really important, because it tends to allow healing and move it away from the scar end to the spectrum to the regenerative end of the spectrum. We use this material in a RCT that will be out in Journal of Periodontology, I believe, in the September issue, so in a couple of months. It should be online just any time. And we compared it to the gold standard, the connective tissue graft. And we had a 25-patient study. We looked at time points both 6 and 12 months. We looked at recession depth as our primary efficacy parameter, and you can look at all the secondary efficacy parameters, the traditional ones you would do on any study like this. To get in the study, you had to have at least 3 millimeters of recession. We've been marking the CEJ with a pencil mark just to allow better visualization with our photography. Here we have a partial thickness flap, intraoperative measurements, and you can see that I am suturing the mucograft now onto the periosteal bed, chronally advance the flap, and this is our result at 6 months. Very nice root coverage. Another patient, this is the xenogenic collagen matrix or the mucograft, and the connective tissue control, again, 100% root coverage on both. So our results were that when we looked at all of these parameters, both at 6 and 12 months, the only 2 parameters that were statistically different between the connective tissue graft and the mucograft was recession depth and percent root coverage. Obviously, that's the same thing, same data, just presented in a different way. And what we saw was that at 6 months, with the connective tissue graft, we had 97% root coverage. With the mucograft, we had 94% root coverage. Both of these they improved over time, which was interesting, that the connective tissue graft improved to 99% root coverage, the mucograft improved to 86% root coverage. If you exclude the mandibular cases, and if you'll look at a lot of these studies out there, many studies do not include mandibular teeth because they're more difficult to treat and they're wanting their results to be better. But I always try to make certain our studies reflect what's going on in your practices. I mean, I treat mandibular teeth in my practice, and I want to make sure our studies treat them. But if you exclude the mandibular teeth, then there was no statistical difference between the connective tissue grafts, which were achieving 99% root coverage, and the mucografts, which were covering 91% root coverage at 1 year. An interesting thing that we did not expect was that we actually achieved more keratinized tissue gain with the mucograft than we did with the connective tissue. To my knowledge, this is the only randomized controlled trial comparing to connective tissue as the control that anything has showed more connective tissue, more keratinized tissue compared to the connective tissue graft at the end of the study. So that was an interesting finding. So to conclude about our experiences with the mucograft, the percent of root coverage and the percent of sites achieving 100% root coverage were in the upper limits of expected range. If you look at meta-analysis and systematic reviews, we achieved that with less morbidity, less technique-sensitive procedure, and better aesthetics. There's a potential to reduce undertreatment because we don't have to rely on the palate. We're increasing keratinized tissue over the connective tissue graft. There are studies ongoing about using this material to increase tissue thickness, increasing with the keratinized tissue, and it may be a good carrier for bioactive agents. You know, other studies have to be done to look at binding and release kinetics, but there's a lot of good bioactive agents out there, but most of them are paired with pretty poor carriers, and this may be a better carrier. We'll just have to see. We're also exploring this with a lot of other things. This is a patient that actually I just did the surgery 2 weeks ago, so it's a very short-term result, but I found it interesting. Her chief complaint was aesthetics. She didn't like the hyperpigmentation in her papillas because it was shown in full smile. So I just went in. I'm going to just excise the pigmented tissue. I'll keep that as a little pattern. Then put it on the mucograft and cut around it. I suture it in place. Here it is at 1 week. You know, I would traditionally do this with connective tissue, and I guess that's a pretty outstanding result for 1 week. You see very little inflammation, nice healing. Same patient, 2 weeks. We're continuing the tissue maturation, and the smile at 2 weeks, you know, not a bad result. So we're learning that we can use this material in a lot of different applications. Let's move from the biologically based devices to the live cell-based devices that we've been doing studies with. And the one that we've been working with over the last few years is the living cellular construct. You know, these devices bring with them not only the cells, but they bring all sorts of cytokines and collagens and glycoproteins proteins that are necessary for regeneration. But to me, the most exciting thing is the potential that they can deliver these things on demand, because these are living cells that have little surface receptors. They're talking to each other. They're talking to the cells in the native environment. And one of the struggles we've had with biologically active agents is that, you know, we know these are potent, for example, BMP. And so we place it down in the defect and we stand back and we wait for magic to happen. But magic doesn't always happen, and why is that? Well, there's a lot of reasons, but some is, how do we know that that got to where we wanted it? How do we know it stayed there long enough? How do we know that it was still viable? Maybe we have too much, maybe we don't have enough. Well, theoretically, with these live cell devices, because they're talking to the native cells, they can physiologically titrate the exact amounts that we need for regeneration. And in addition to that, you know, regeneration is a complex thing. And to be able to kick it off with a single agent, you know, that may be a bit naive, but, you know, that's kind of where we're at right now. Now, anytime you and I are faced with an oral mucosal defect, we've got a variety of ways that we can manage it. Most of the ways that we treat oral mucosal defects today end up with primary intention as what we're trying to achieve. You know, we're going to mobilize a flap and we're going to suture it, or we're going to harvest a graft and we're going to close a defect with the graft. Or we can utilize secondary intention, in which we just let it granulate in. Obviously, that's fallen out of favor because of pain and inflammation and time, but, you know, it is an option. But regardless of whether you choose primary intention or secondary intention, there's a spectrum of wound healing that all this falls on. And way out here beyond this panel is a big keloid. You know, and then we have a hypertrophic scar, and then we've got a tissue mismatch from a graft that I did, all the way to the other end of the spectrum where animals like newts and salamanders can actually regrow appendages through enhanced forms of secondary intention. We know that kids heal faster and better than adults. We know that fetuses heal without a scar. So our job as a clinician, we want to move our healing from the scar end of the spectrum to the regenerative end of the spectrum. And the material that we're using in these studies, the living cellular constructs, operates in that way. It is not a tissue replacement graft. You'll have to begin to alter the way you think about this, because this doesn't work as a graft. When you use a tissue replacement graft, those cells of the tissue you're using, they stay there, and they stay there, you know, forever, basically. So if you're taking tissue from the palate, those cells will always retain their palatal phenotype, and you have the other problems associated with the, you know, lack of donor material, the morbidity of the donor site. And one thing that we don't always think about is that if we close a defect early, say through a graft, you can actually abrogate the body's innate ability to regenerate. Where these living cellular constructs, what they do is they alter or modulate healing through secondary intention. And again, another thing that most of us don't think about is that think of any model of regeneration, neonatal, animal, fetal, all models of regeneration always operate through secondary intention. And so here you have this wound, this ulcer here. If you were to apply, you take a graft from, say, the thigh and you place it over there, you would always see it might close it, but you'd see the boundary of the graft. But look what happens here after the living cellular construct is applied. At 3 weeks, not only is it healing, but by 6 months, you have the natural pigmentation here. And that's because this material is modulating healing through an enhanced form of secondary intention. The same thing happens in the studies that we've been performing. Now, in these studies, we're just simply trying to generate keratinized tissue. We're not trying to do root coverage, but if you'll look here, I think you can appreciate this purely mucosa. I've created a traditional bed, as you would for any free gingival graft. If I was using this living cellular construct simply as a biologically based Band-Aid that's going to speed healing and end up without a scar, that would do that, but we'd end up with the same tissue that we had before. But this doesn't work that way. It actually alters the trajectory of healing, providing site-appropriate differentiation. What that means is we end up here with keratinized gingiva where we only had mucosa before. And it's doing it not as a graft, but through modulating secondary intention here. Now, this material was originally made as a skin replacement graft. And if you're a cool tissue engineering guy and you're wanting to make a skin replacement graft, let's make it look like skin. And indeed, they were able to. You know, you have an epidermis with living keratinocytes. You have a dermis with living fibroblasts that comes from neonatal cells. But what we found out, and what was found out, was it's not the anatomical resemblance to skin that's important. What's important is the fact that when you have keratinocytes and fibroblasts together, there's a lot of crosstalk. There's synergism. And if you look and you have insulin growth factor or interleukin-8, neither of these cytokines are produced by keratinocytes alone or by fibroblasts alone. Yet when you have them together, you're getting these cytokines produced. And if you look at the broad array of the cytokines being produced by living cellular construct, look at all the ones that we already know are important to periodontal regeneration that this material produces. BMP, fibroblast growth factor, PDGF, VEGF, TGF-beta1. One of our problems is we know these are important, but how do we access them? This material would provide a natural reservoir for many of these cytokines that we know are important to periodontal regeneration. Along with that, it provides, along with the cells, it provides the extracellular matrix components important for cell migration, structural integrity, inflammatory modulation. And to me, the most important thing is its potential to deliver on demand. Now, this is an in vitro, not an in vivo, but if you look at the in vitro expression of these cytokines through mRNA analysis after stimulation, you see that some of these cytokines they're being upregulated because of the stimulation. In other words, they are reacting to the environment. They're providing what the environment needs. And in our pilot study, we wounded the tissue, the device, to upregulate these cytokines. And concrete proof that this device is living is that if you look at 0 hours and you cut through the epidermis, at 12 hours you see the keratinocytes beginning to grow over the surface. Now you have the keratinocytes completely covering the surface, and by 5 days, a fully differentiated epidermis over dermis. We used that material in our pilot study that we published in Journal of Periodontology in 2008. And we were doing this simply to see, could we create keratinized tissue? We're not trying to cover root surfaces, and our control in this was the free gingival graft. We used a triple layer of it to improve handling, keratinocytes on the outside, fibroblasts on the inside. And this, of course, is what we're trying to avoid. None of us want to have a limited amount of donor material that creates significant morbidity for the patients. It comes in a bioreactor. You can graft the entire mouth with this bioreactor. It has around a 10-day lifespan once it receives you, and I like to think of it as a lifespan, not a shelf life, because this is living material. And here you see one of our patients in the pilot. This is the living cellular construct on the top, the free gingival graft on the bottom. At 4 weeks, you can appreciate we're beginning to get a nice mucogingival junction, a nice zone of keratinized tissue. Same thing going on with the free gingival graft. If we follow that out to 6 months and we stain these panels with Schiller's iodine stain to differentiate the mucosa from the keratinized tissue, clear differentiation, nice zone of keratinized tissue, obviously is withstanding muscle pull. Another patient from the pilot study, the LCC on the top, the free gingival graft on the bottom. And if we center in on the 6-month panels here, you know, this is a very nice result with the free gingival graft, a nice functional zone of attached gingiva. But you certainly can tell that we have tissue from a different site. You know, this will always retain its palatal phenotype. You can see how much nicer this looks than this, and that's one of our goals, and I'll expand upon that in just a moment. So in our pilot study, we looked at all of these parameters, and at 6 months, the only parameters that were significantly different between test and control were these. And we'll look at each one of these. If you look at with the keratinized tissue, the free gingival graft was superior. It in fact achieved about twice as much keratinized tissue as did the LCC, but we found the LCC to be safe and capable of generating, without a donor site, keratinized tissue up to 4 millimeters. 24 out of 25 of our test sites demonstrated an increase in keratinized tissue, and 3/4 of the test sites yielded 2 millimeters or wider bands of keratinized tissue. If we look at changing color or texture, the test graft won. And that's because this graft doesn't work like a tissue replacement graft. It's creating de novo regeneration. So again, if you look here, yeah, that's a nice functional result, but if you look here, it looks much, much more natural because it's not acting as a graft. It's causing the cells that belong there to populate and to fill in. And then the other area that there was statistical significance was subject preference, and you can guess, you want your palate carved on or do you want to go to the bioreactor? So we used those positive results. We moved that into a large multi-center trial. These are the centers, our group with Dr. Shire and myself in Houston, Drs. Cochran and Melling in San Antonio, Dr. Gianobili and Nevia and Morelli in Michigan, and Mark Nevins in his office in Boston. 96 patient study, 6-month follow-up. Our primary efficacy parameter was gain in keratinized tissue greater than or equal to 2 millimeters. Our secondary efficacy parameters, color, texture, patient preference, and pain and sensitivity, and then we looked at a lot of other secondary measures. Now, we changed things based on pilot data. That's what you typically do. You do the pilot studies, you decide what works and what doesn't. And one of the things we ended up doing was to place a broader zone of the tissue-engineered device. We're no longer standardizing width between the keratinized tissue and this. It didn't make sense because it's not a graft. If it's not a graft, then it doesn't make sense to try to standardize that. Here you can see, you could just, pure mucosa here, and at 6 months with the LCC, a nice zone of keratinized tissue, very equivalent to what we've got with our free gingival graft. Another patient, again, with the LCC, nice zone of keratinized tissue, and you don't get that scarred look. And a final one. And this one I think is particularly a nice patient to look at, because if you look at the pre-op on both the test and the control, absolutely no doubt that we just have movable mucosa. There's no keratinized tissue here at all. You could just see that. And what do we have with the free gingival graft? Well, we've got a nice functional zone of keratinized tissue. That was our goal. We achieved it, but certainly a tissue mismatch. Look at the nice functional zone of keratinized tissue that we have achieved here. And that's really where we're going. With our surgical guidelines and our traditional periodontal plastic surgery, we know what we can accomplish as far as generating keratinized tissue or covering root surfaces. The next step is to take it beyond that so that we're creating tissue indistinguishable from what Mother Nature intended to be there. And that's where we're heading with this type of technology. The conclusions were that the LCC is effective and well tolerated in a non-submerged wound healing environment, both with our pilot and the pivotal trial, that it generates more than 3 millimeters of new keratinized tissue, provides improved aesthetics, greater patient preference without donor site morbidity. And this data is now before the FDA. Another area that we've had great difficulty in managing with traditional periodontal plastic surgery is trying to grow papillas. And it's one of those things that we can all show our case reports, but if you look at all the literature out there on papillary reconstruction, most all of them are either case reports or case series, and I'm not diminishing. I've learned much from all of these. But this represents the first, and I believe only, randomized controlled clinical trial in an effort to try to regrow papillas. Now, we're going to do it in a bit of a novel way. We're going to take a small sample, a biopsy of the patient's tissue from the palate. We're going to then send that to the laboratory. We're going to separate the cells, and we're going to grow out the fibroblasts to about 200 million fibroblasts per ml. It's going to be put into an injectable medium, and then we're going to inject that into the deficient papilla. Not injecting collagen or a filler here. We're injecting living fibroblasts that have the potential not only to maintain this, but to perhaps improve it over time. We're learning more and more about gingival fibroblasts. One of the interesting things is you can get more undifferentiated cells from gingival tissue than you can any other cells than any other tissue in the body, more UMC cells. And if you stimulate them in the right direction, they have great phenotypic heterogeneity. Of course, they are producing all sorts of cytokines, again, many that we know are important for periodontal regeneration, but they are important for cell proliferation, extracellular matrix production, growth factor production, cytokine production. So here is our magic potion. This is not collagen, this is 99% pure fibroblasts, and I'm going to inject into this papilla, right? Well, maybe not. Most of you in the audience, you've injected local anesthetic in papilla. You know it's firmly bound down. Why do I think I'm going to be able to plump that out? This material was devised for smile lines and wrinkles on the face, and you can imagine how you might be able to expand that, but not a papilla. Of course, I knew that as well, so we had to develop what we call the papilla priming procedure. It's just a minor little surgical insult into the papilla, which will cause swelling. So here we're doing the papilla priming procedure. You see the swelling at 3 days. At 7 days, it's still swollen, but not quite as acute. And by 21 days, the tissue is completely like it was before. Well, how can we leverage that to our advantage in this study? Think about what happens with wound repair. I think it's best to envision, what goes on during the phases of wound repair. And we have typically 3 different phases. We have the inflammatory phase, the granulation tissue formation phase, and the matrix formation and remodeling phase. And when you look at it in a temporal model like this, it looks very fixed and unyielding. But in nature, these phases can overlap a great deal. They can go for different lengths of time, so it's not quite as fixed as it looks in the textbooks. But let's think about what happens when we begin the papilla priming procedure. Within seconds of performing the papilla priming procedure, you begin wound repair. Plasma proteins, primarily fibrinogen, coat the wound, and everything begins. Within minutes, you begin the early component of the inflammatory phase. Neutrophils are flooding in here. The body knows it's wounded, so it signals its own fibroblasts to begin to produce more fibroblasts. These fibroblasts are producing collagen. They're trying to heal the wound, and you get swelling above baseline. At about 3 days, you're entering the late phase of the inflammatory component. The neutrophils are going away, the macrophages are coming in, they're cleaning up the wound, but the macrophages are also producing all sorts of cytokines that are improving angiogenesis, that are doing a lot toward wound healing. But as we move into toward about 5 days, we're moving into the granulation tissue formation phase. And what's happening there is, at around 5 days, the body says, okay, I'm tired, this is enough, you fibroblasts, shut down. And so the body shuts down the production of its fibroblasts, collagen accumulation begins to wane, and you go into the wound contraction. Now, most people think that the amount of tissue you end up with after a wound depends on the length of the granulation tissue formation phase. So theoretically, if you have a short granulation tissue formation phase, what that means is the fibroblasts are not there long enough to produce enough collagen to fill that wound, so you could actually end up with a net loss of tissue. If, though, we could increase the granulation tissue formation phase, the fibroblasts are there for a longer period of time, they're producing more collagen, and theoretically you can end up with a net gain of fibroblasts. And that was our experimental model or concept that we devised for this study. And that is, through strategic injections of the patient's own fibroblasts, we're going to try to expand or lengthen the granulation tissue formation phase here. Now, what happens when you inject these fibroblasts, they take their part in the normal dermal architecture. They go through 1 or 2 mitotic rounds, and then they take their place, and they begin to produce collagen, stimulate nascent cells to produce collagen, thickening the dermis. So in our study, we either injected placebo or we injected 20 million fibroblasts per ml. And note, we did our first injection at 5 to 7 days. And why did I choose that point? Well, that's when the body's shutting down its own fibroblasts. So just as the body's shutting down its own fibroblasts, I want to hit it again. And we dosed it for 3 different times over a 3-week period, so that we try to get in the most fibroblasts as we could. Now, we looked at outcome through a lot of ways, but the way that ended up being the most sensitive was through digital photography with digital analysis. This panel will always be the before, this will always be the after, and these are input and output images, which are really easier looked at in a graph. Now, the y-axis, at the top of the y-axis, that says 2 millimeters and it says 0 here. So that means up here you have a 2 millimeter open interproximal space. Down here you have no open interproximal space. So this first dot, that is our papilla priming. Here's first injection, second injection, third injection. What I want to draw your attention to is this is the third injection. After this point, no other injections took place. If we were just injecting a filler, that's all you're going to get. But look how from that third injection, the space continues to close down, then we get a little rebound and better. How does that happen? It's because the fibroblasts are sitting there, they're producing the collagen. Another patient, papilla priming. Look, you get some closure of the open interproximal space from the papilla priming simply because of the swelling, right? But here's your first injection, second injection, third injection. No more injections after that, but look at that open and proximal space close as the fibroblast sets there, producing collagen, thickening the dermis. Now, you can do anything on a computer. This is not computer enhanced. This is simply a time lapse from day 0 to 4 months. So I want everybody to look at this center panel here. So we now know it's possible. If we can find it's predictable, I'm going to be opening papilla parlors next to every Bright Smile clinic across the United States. We concluded that autologous fibroblasts were safe and might be efficacious for the treatment of open and proximal spaces. The investigators and subjects both found the visual analog scale assessment of test site superior to placebo, but our objective endpoints failed to demonstrate statistical significance, and we needed further studies to come up with more appropriate power and more sensitive measurement techniques. Let's look at this patient here. This is day 0. I'm injecting the fibroblasts. At this point, I didn't know whether it was fibroblasts or the placebo, but this was fibroblasts. We're injecting somewhere between 6 to 8 million fibroblasts into this papilla. And you see it blanched just as you might if it was local anesthetic. So here it is at day 0, right before we did the 3 injections. And here we have at 4 months at the end of the study. Certainly improvement. But the reason I'm showing this is this patient is still in my recall. She happened to be in my office a month ago. Here she is at 5 years. Not bad. And again, if you think theoretically here that these fibroblasts can sit around and continue to produce collagen to the limits of the embrasure shape. So again, I think there's potential with thinking out of the box, thinking in these ways. I don't know any other way you could have done something like that. Let's move from the live cell end of the tissue engineering matrix and finish the program with biologically active molecules. And we'll talk about a couple of studies that we've done with beta-TCP and recombinant PDGF, and since we're talking brand names, evidently, this is the GEM21S. We did a pilot study here comparing the PDGF versus connective tissue. And our primary efficacy parameters was an absolute change in recession depth, but we also looked at clinical attachment level, probing pocket depth, amount of keratinized tissue, and more tertiary variables as well. Now, our components were the beta-TCP. This is a biocompatible osteoconductive scaffold for bone formation. It prevents soft tissue collapse. That's why I used it, to prevent the tissue from collapsing onto the root surface, and it facilitates the stabilization of the clot. The real workhorse here, the important component though, is the PDGF. We know more about PDGF than any other growth factor in all of periodontics, all of dentistry. There are more studies, clinical and preclinical, about this than anything else. It is a purely synthetic cell signaling growth factor. It's mitogenic and chemotactic for both bone and PDL cells. It's angiogenic